Hello, everybody, and welcome to this week's Skills Moment. Every Wednesday, I will be coming on live and offering you an opportunity to ask questions, get your questions answered. If you ask questions during the week, I will be addressing them on this live and making sure that we're checking in. But I also want to address any concerns that come up. This week, it has been brought to my attention that one of the main focuses of conversation in multiple groups is duplicate services. And I want to talk to you about that because this is something that obviously I've faced, I've heard a lot, but also I've never had one of my treatments successfully denied payment because of the way I document. Whether it was in SNF, whether I was doing treatments in ALF, whether I was, treating an outpatient, the way you document and the way you write your goals, that's everything. Where are you coming from as an occupational therapy practitioner? And that's what I want to talk to you about today. On the BOT portal, there's a training for SMART goals. I am currently making one for defensive documentation, but for now, I would encourage you to go and take that course on SMART goals. This is a non-CEU course that's built into the Connect mentorship program. Now, this is, I believe, stage 1, phase 3. So if you're not there yet, you can either skip ahead or you can go in order. But I would encourage you to watch that video and then read through some of the documentation examples for SMART goals. I'm going to be revamping them again with the color coding system so that you can see where and why OT lives in every single part of the remediation process, okay? Always referring back here. And of course, there should be another blue dot right here. So we start with occupation, and then we have to address body functions, structures, skills, blend it into an activity, and then finally integrate it into an occupation-specific activity. Especially if you're working in SNF or ALF, you want to make sure that you're going through and providing a continuum of care within your plan of care, your evaluation and intervention process. Okay, so that's what I'm going to try to take you through that journey today, and today's video is specifically on balance and stability. What do you do when PT is in the mix, as they are, right? What do you do when you also need to work on body functions, structures, and skills while they are billing for balance? That's number one. Number two, PT also throws in those functional words like patient will improve balance for functional ambulation or transfers or bed mobility, whatever it might be. If your patient is sufficient with activities of daily living, what do you do? Can you still bill for these types of functions? Absolutely, 120% you can. That's the quick answer for that. But how do you get your note? How do you get your billing reimbursed if they are also present? Okay, so let's live there. Remember that you're an analyst. Always come back to that. The details are everything. The details are what's going to get you paid. They're going to get you reimbursed. We have had soft audits here, and I have been soft audited in skilled nursing facilities. We've been hard audited in skilled nursing facility settings, and we have never had an issue with duplicate of services, and I'll tell you why. I've always demanded that my practitioners, as well as myself, bill with specific OTPF language, always giving rationale for what and why they are doing what they are doing. A lot of administration will say, no, make sure that an ADL is somewhere on there. But that's because they don't know that we have a huge realm to pull from, and they will never know that. And insurance companies will never know that unless we start using it in our documentation, unless we start using this language and putting it in our notes and being prepared to defend it. They will never know. And that's why I teach defensive documentation. That's why when you go through our new color coded treatment rationales, you see all of that language within our notes. Those aren't just rationales, those are our intervention notes. That is the objective section. I expect to be in every single one of my therapist notes, because, as well as myself, because that protects us from being audited and telling us that we're working outside our scope of practice, number one. It also relates it back to one of the 9 subdomains of occupation. All of them are pointing back to what you all should have and know our framework, okay? Tables 8 through 13, I'm constantly flipping back and forth. If I'm building a new note rationale out, I'm constantly flipping back and forth. You have to include this language, and you have to include the occupation you're working towards. That right there will guarantee that you will receive payment. Physical therapy does not go into all of these dimensions. They may have them listed in their practice guidelines, but they don't know how to use them or leverage them, because we are occupation. That means if we combine analysis with occupation, we can, quite frankly, manipulate the heck out of it. There's no limit to what we can do if we can document appropriately, sufficiently, and thoroughly. Find out as a team what they're working towards. What is physical therapy's notes? When I worked in the medical rehab unit, when I worked in a team on SNF and in outpatient, I find out what the other therapists are working on. Then I stay away from it. I'm the only one that can pick and choose what I'm doing. I'm the only one that can adapt around somebody. You see, speech therapy and physical therapy, they're linear. They're not multidimensional. They have a specialty, which great for them, that's great. Even better for us, because they're limited, we're limitless. We have everything to pull from because we manipulate both science and social and use it for a patient-directed goal. You have to get more confident in that. You have to get more confident in that. You have to get comfortable with your language. The language you're using, both verbal and written. When you start becoming this, you know you can't be touched, okay? If your physical therapist on the team is working on ambulation, mobility, generally they work on bed mobility, transfers, and ambulation. Okay, that's fine. What other occupations does your client need to do and have balance for? So if you're talking about balance and stability, you know that there are two different things. Balance is internal. It's like an internal response to inertia. You have to be able to correct to midline. You have to be able to use those anticipatory postural reactions. You have to know where your body is in space when that force activates. So balance is equilibrium without acceleration. You're not moving. You're standing still. You're not moving from point A to point B. Typically, you're in a static position requiring some level of activity engagement, okay? Can you tip your trunk and come back? Can your patient go ahead and stand at the sink? All linear, right? We stand at the sink and we do our dishes, our elbows are tucked, we're doing our dishes. Can they stand for more than 10 minutes without experiencing posterior lean? With some diagnoses, it's like a dimmer switch, right? Especially in the basal ganglia. If you stand statically for too long, it's like the dimmer switch comes all the way down in your body, forgets what it's doing, and it just starts tipping. Having balance is necessary for sitting unsupported while eating, sitting unsupported while grooming, standing, even with bilateral upper extremity support, just standing statically. Can your patient do that? Why are you working on the skill? Many physical therapists don't even know there's a difference between balance and stability. Stability requires strength and balance. Stability is active use of balance through mobility. So walking, engaging in a multi-activity occupation within context. All of these things require stability, the root of that being balance. What are you working on? If they got balance, then you got stability. Fine, work on balance. Odds are they're working on stability and they just don't know it. That's okay. That's all right. They got balance. You have stability and you can explain the difference between balance and stability. Go a step further and put that right in your note. I put that right in my note. I'll put it in my assessment and I'll put it in my treatment and I'll say, speech therapy is working on X, Y, and Z. PT is working on X, Y, and Z. OT is working on A, B, C, D, E, F, G, because all of these skills are needed for occupation ABC. I am so detailed in my notes because I don't want to fight the system. I want the system to recognize me. That's why I have this thing almost memorized. At first, my notes took me a really, really long time, and new notes do take me a long time. But if you'll notice, I use this language in my speech. I don't need to reference it. I know it. It's part of who I am. That's what we have to get to as a profession. If you're working on balance and stability, number one, know what they're working on and stay away from it. Number two, know and understand the deficit. What part of balance or stability is being implicated, and what do you have to work on to help that? If balance is impacted, so equilibrium response is impacted for a variety of reasons, right? Do you have to do some sensory enhancement interventions to be able to leverage the tactile system and the visual system to compensate for the balance or proprioceptive dysfunction? Can you remediate proprioception for the sake of balance? Do you have to first work on strength in order for the body to sustain all of its structures while its balanced system is being provoked? Go through each thing, right? Go through each thing and think about it. Don't panic. That would be my number one piece of advice is, first of all, don't panic. If you're initially rejected for reimbursement, don't panic. Put on your analyst eyes. What are they billing for? What are you billing for? Where is the lack of education? Are you not communicating your value? Are you not communicating why you're doing something effectively? Does it appear that you are using the same language as PT? Because I'll tell you right now, our language is not the same. So if you spent your career trying to be PT and bill for PT because that's what's understood and that's what gets billed for, that's what gets reimbursed, you're doing it wrong. Are you using your language? Or are you using theirs? You're an analyst. They are not. They are not analysts. They don't know the details. They aren't trained to know the details. Furthermore, with balance and stability, if you're nervous, why not take the psychosocial route? Use an ABC confidence scale. Use a modified falls efficacy scale. Use another form of a patient assessment, a patient perception-based assessment. Are they nervous? Are they scared? Maybe do an environment-based assessment. Does the environment have to be modified? Do you have to help your client traverse their environment? Walking through corridors, changing from different surfaces, visually interpreting and acting upon these changes between rooms. There's so much more to address than just therapeutic exercise. We use the same assessments, we use the same interventions, but we have the breadth of what we can address is so much bigger. There's never any reason why we can't be working on the same types of things. And we should never be scared of it because we need to dominate what we are allowed to do. We need to be confident in what we do. And a lot of this comes from that. Okay. I would encourage you to head into your Connect program. I would encourage you to go through the SMART Goals course. I would encourage you to go through the SMART Goals we have, which is being converted into the color coding system. Also, taking and going through our new documentation database. I'm converting those to a color coding system. Take time to look at what's on the portal because I've taught it. I have resources teaching you these things. Our neuromuscular reeducation course or our balance systems course, our body systems course, takes you through balance and stability and what you can do to impact those systems. Knowledge is power. It comes from the knowledge of the human anatomy, kinesiology, physics, body mechanics, all blended with our OTPF, and that's the portal. That is full scope OT. So I would encourage you to make use of the Connect mentorship program, make the course, make use of the other courses, make use of all of the resources that are on there because I've spent years putting it on there so that you are equipped with full scope knowledge. Never back down. Just show up. Show up as an occupational therapy practitioner and know that you don't have to feel imposter syndrome because you have every right to work on balance and stability. You have every right to work on functional ambulations, transfers, and bed mobility. It's all in your scope. It's just all in the way you phrase it. Okay? All right, take that back and talk with your Marco Polo groups about it. Also, comment below on this post if you're on the portal watching this. Engage with your community, engage with your professional network. That's where it all comes down to when you're building confidence. All right, that's it for today. I hope you all have a great week and we'll see you next week.